So really the first case nicely leads into the second talk today, which I'm presenting on behalf of my colleague Christopher Monkhouse, who was unable to attend. And in this scenario, we're going to look at a real-world single-center experience, looking at the SICD and smart pass deactivation and how this impacts on inappropriate shocks. So the SICD has been increasingly used in those at risk of sudden cardiac death, with its addition to HRS and AHA guidelines in 2017. Now, its unique feature of entirely extracardiac position means that the SICD is a Class 1 indication in those with complex anatomy, venous access issues, or those at high risk of infection. So there have been several studies, as I'm sure you're aware. So the Effortless Registry in 2014 found an inappropriate shock rate of 7%, and this was mainly due to T-wave oversensing. They also looked closely at single-zone and dual-zone programming, and it was found that actually with single-zone programming, the risk was 12%. The Praetorian trial, published in 2020, found an inappropriate shock rate at 4.8% at 1 year and 9.7% at 4 years. However, the risk at 1 year was very much comparable to transvenous systems, which was 4.1%. Now, of the inappropriate shock risk, 58.5% of these cases were actually attributable to cardiac oversensing. The Untouched study in 2020 found an inappropriate shock rate of 2.1% at 6 months, 3.1% at 12 months, and 4.1% at 18 months. Now, you'll notice there's a little bit of disparity between Praetorian and Untouched, and this is due to the inclusion of more third-generation SICDs in Untouched, in which we're able to use Smart Pass. So the objectives from our audit was to understand why Smart Pass deactivates, assess the effects of Smart Pass deactivation on inappropriate shock rates, and also to develop a strategy to manage Smart Pass deactivation. So first of all, what is Smart Pass? So the SECG will pass through amplifiers and then onto wide-range filters. The next phase is where Smart Pass is applied. Now, Smart Pass is a high-pass filter with a frequency of between 8 and 9 hertz. And it allows for the gradual reduction of lower frequency signals and preserves those higher frequency signals which are greater than 10 hertz. Now, importantly, T-waves are usually around less than 9 hertz of frequency, and therefore Smart Pass reduces the R to T-wave ratio and subsequently oversensing occurrence. It is, however, important to note that Smart Pass can deactivate itself. And the reasons it can deactivate itself is due to the presence of lower amplitude contiguous beats of less than 0.25 millivolts, and one of the following. This would be long intervals of greater than 1.4 seconds or 10 seconds of asystole. Now, when it does disable, it will upload a Smart Pass episode to Latitude. And the reason it disables is to minimize undersensing, as the additional filtering applies can reduce the signal amplitude by 30 to 50%. And it can only be reactivated in clinic face-to-face. Although the alert is for Smart Pass, it does inadvertently act as a small R-wave bradycardia or asystole alert. So the method. So we, as I say before, we were a single-center institution, and we retrospectively conducted the audit. We looked back at all SICD implants of the A209 devices and the A219, and these were implanted between 2016 to 2020. We accessed latitude and electronic pacing in health records, and we were able to collect baseline characteristics, SICD programming, which encompassed sensing vector, tachy zones, and Smart Pass status at implant and throughout the follow-up period. Statistical analysis was conducted, and we used univariate and hazard analysis. The endpoint was the first SICD therapy, and each patient was only registered once. So the results. So a total of 348 patients were analysed, with a mean follow-up period of 27 months. There were a larger proportion of males at 68.7%, with a mean age of 45.7 years. Most patients had the SICD implanted for primary prevention indications. There were a total of 83 shocks across 41 patients. And of these shocks, importantly, 44 were inappropriate, which equates to a 7.8% inappropriate shock rate. Now, only one of these shocks was due to aberrant AF. So looking at the Kaplan-Meier curve, this encompasses all patients in the cohort. We have an x-axis showing the number of years where day 0 was SmartPass deactivation. We have a y-axis showing the survival from inappropriate shock. Now, the rhythm triggering the first inappropriate shock was used for calculating the incidence of inappropriate therapy. It was found, importantly, that SmartPass was a significant predictor of all therapy and inappropriate therapy. And the graph nicely shows the time frame in which we have to manage these programming changes. You'll notice that there are a few very initially after implant, and these are patients with air entrapment within the sensing circuit. Now, it's very difficult to manage these patients in the quick term, and they usually allow the air to dissipate over 2 weeks following implant. However, if we look further along, we can see actually we would have a number of weeks to bring patients to clinic for programming changes to reduce the shock risk. So we also conducted a univariate analysis comparing individual variables to those that have been previously published to be associated with a higher increased rate of inappropriate shocks. So looking at the hazard ratio, we can see that SmartPass deactivation has an odds ratio of 7.76 times of inappropriate therapy. Now, looking at the other variables we found, so age, atrial arrhythmias, etiology, and poor LV function, actually none of these were found to be significant in causing a greater risk of inappropriate therapy. So 32 patients had SmartPass deactivation, and one patient was due to implant, a poor R wave, and went on to have inappropriate therapy due to air entrapment. 2 patients had SmartPass disabled, and unfortunately, before attending clinic review for reactivation, went on to have inappropriate therapy. Now, the SmartPass recordings were available for 17 out of the 32 patients. So one patient, as we can see, one patient had a bradycardia asystolic event, and actually this patient went on to have extraction of the SICD and upgrade to transvenous system. 5 patients had a periodic axis shift in their R wave, and this is due to arrhythmia, which can equate to PVCs, SVTs with aberrancy, or idioventricular rhythm. But the largest proportion was those with small R wave amplitude. So we can actually see that only one patient with periodic axis shift went on to have inappropriate shock, with the larger proportion being associated with the small amplitude R wave. So a couple of examples of the traces that we collected. So first of all, we can see that on these traces that SmartPass deactivates at between 17 and 18 seconds. So this patient is the asystolic patient who went on to have an upgrade to transvenous system. The next patient we can see had a rhythm where there is a sudden change in the QRS axis. Could be bundle branch block, could be an idioventricular rhythm, but again, there is undersensing, resulting in SmartPass deactivation. And finally, we can see an example where there are small R waves, but also this is coinciding with bradycardia with an interval of greater than 1.4 seconds, resulting in the deactivation. So how did we manage the risk of inappropriate therapy in these patients? So as you will recall, there was 25 patients in which had therapy, and 10 patients of these had SmartPass disabled. So reasons we can see as previously. So in one case, in 2 cases, there were no changes, and unsurprisingly, they went on to have one further inappropriate shock. The following, we temporarily deactivated the device in 2 patients, and this was due to air entrapment within the sensing circuit. The patient then reattended for reactivation of SmartPass. We then also looked at reactivating SmartPass and adding ×2 gain for 1 patient. And there was also an increase in device detection rate, and this was where we increased the conditional shock zone from 200 beats per minute to 220 beats per minute. 1 patient had an up-titration in their bisoprolol, and this resulted in prevention of further inappropriate therapy. Electrode reposition was necessary in 2 patients, and explant of the SICD to a transvenous system was also required in another. But however, the most management change that was conducted most often in 60% of our cases was changing the sensing vector. So go through just a flowchart that we have developed as a management tool. So firstly, and most importantly, ensuring that SmartPass is activated post-implant. And to do this, you would need to run automatic setup. And this is available on the A209 and the A219 devices. So when you first identify SmartPass has deactivated, the first step would be to review the SmartPass episode on latitude. Now, if this trace identifies bradycardia or asystole, at this stage it would be pertinent to consider an upgrade to a transvenous ICD. However, if it's due to R-wave undersensing, it's important that the root cause of this undersensing is identified. Now, there are 2 possible causes, one being air entrapment within the circuit or small amplitude R-waves. Now, if air is detected, SICD therapies should be temporarily deactivated to allow the air to dissipate. But if undersensing is the result of small R-waves, again, the same management strategy would be to re-enable SmartPass, and if this is successful, you can revert back to routine follow-up. However, if this is unsuccessful, you should then consider changing the sensing vector. However, again, if the problem does persist, the patient should then be rescreened. And at this stage, it would be important to gain an up-to-date chest X-ray on the electrode lead position and also repeat screening of an alternative position. Now, at our institution, we routinely conduct right-sided screening also. And when considering chest X-ray, both PA and lateral views are really useful, and it's important that you compare these images to the original X-ray post-implant. And if you find that actually sensing screening is successful in the new optimized position, then you should then move on to lead reposition. However, lead reposition is not always the most appropriate option if the SICD is already in an optimal position. So to conclude, SmartPass deactivation is a 7.76 times risk of inappropriate therapy. Deactivation of SmartPass is also a sign of low amplitude sensing, bradycardia, or asystole. Now, timely management of SmartPass deactivation should reduce the risk of inappropriate therapy. References, and thank you very much for listening.